you and hear you, but I know it will be a good session, just as we are. I want to thank the Champlain Hospice Palliative Care Program and Carl and Tara in particular for this opportunity. So my name is Lacey White. I'm an assistant professor at the School of Nursing at Cape Breton University, and I'm going to share a little bit more about myself in some time. But first, the kind of housekeeping in terms of just sharing with you, I don't have any financial interests or relationships or conflicts of interest as I begin this presentation. And I also like to share with you where I'm sitting here at Cape Breton University. It's in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. And this is about 5 minutes from where, very close to where I live. And the ocean is off in the distance there, but I also really love this picture of the rural feel of where I am, and the blue heron looking out and witnessing what is going on. So also, I'd love to know who's in the room, so to speak, in terms of this is going to be an interdisciplinary conversation. It's shaped by my nursing lens, but I know there's a lot of wisdom in the room. So if you could share where you're coming from, and if it's not in the list, please let us know in the chat box. So I'll give you a few moments for that. Great, thank you. Excellent. It's great to see the other ways people are showing up in the world and doing this work, and thank you for joining us.
Okay, and just to read it out for folks, looks like we have 2 people from Allied Health here and 15 nurses, 4 doctors or nurse practitioners. We have a paramedic and a social worker or a psychologist. We have 2 personal support workers, 2 spiritual care workers, 7 volunteers, 4 caregivers, and 5 others who are just writing it in the chat there.
Great. Thank you, Carl, and thank you, everyone. So as Carl said, throughout this presentation, it's not a presentation, I hope it'll be this interactive engagement and conversation. Please feel free to chat, put something in the chat, and be happy to respond as we go along. And I'm looking forward to learning with you in this conversation. I named 3 learning objectives, and really the big one is, what do we mean by holistic practice and palliative care? And there's different lenses on that, there's different views, so I'm interested in what your perspectives are, and to share some in relation to contemplative practices and to try out some of those contemplative practices, and then also to consider how they might connect, how contemplative ways of being and practices can shape our holistic lens in palliative care. So the conversation today, I hope, is not linear and more like a spiral, sharing some stories and connecting these various practices, which I have named here on the left, with the complexity of palliative care work and these holistic ideas. So I invite you to just kind of go along for the journey and to notice what arises for yourself in the process. Some of the stories I intend to evoke a little bit to invite emotion into the room. So much of this work is embodied and relational. So wanting to really invite that into the conversation, and want to invite you to come as you are, and also to take care of yourself along the way. So some practices might not resonate this evening, or you might want to do it in a different way than it's been offered. And so that's okay. And that's great reflections too. You're also welcome to share where you went in your experiences, what questions arose, and what stories arose for you as you hear the stories I'll share this evening. A little bit more about me and how I came to this interest. I have a background in palliative care, but before that, 2 years into nursing, I was in acute care, and I wasn't feeling very good. I felt like my education hadn't prepared me to work with suffering and the existential angst and questions that were arising. And a physician suggested that I try out yoga, and I took this 8-week healthy lifestyles course. This was back in about 2005. And it really helped doing yoga, meditation, deep learning to kind of deeply listen to others who were in the room, breathing practices, and alongside some counseling and some Eastern philosophy, I came to these 2 goals, which is how can I take care of myself even more, and how can I support my colleagues in various ways to do the same, and recognizing that I really was interested in palliative and end-of-life care, and I wanted to start developing some capacities. And it was a number of years later that I had my first palliative care job, and this is a view from the office. In 2009, just over the Golden Gate Bridge in San Francisco, Marin County. I was very fortunate to work with people in their homes, patients and families. And this was just one day, not far from a home I had visited. So those interests took me along, and I really appreciated further developing the contemplative way with meditation, and how it really did help and support the work I was doing as a palliative care nurse. And it also still wasn't very easy. And I was very curious about what these practices had to offer, and also what might the challenges be, which took me to grad school and back to Ottawa. And I was lucky while I was beginning my graduate studies to be able to work at Maycourt Hospice. This is their hallway. And my question as I started grad school was, how does mindfulness, which is another kind of contemplative practice, how can it influence palliative care nurses and their relational ways of being with people through uncertainty and the complexity of the work? And while I was in my first courses, I was invited to write about something I was concerned about in the process of the research. For me, that was writing itself. And I was invited to write into my emotional experience. And what I found arising was fear. I was afraid of the writing. And so I wrote a little reflective piece, which connects with my practice as a palliative care nurse. And I want to share that with you now to kind of frame our conversation a bit more. And this was for a course. So it was the reflective piece goes alongside some other thoughts I had. But here's my story. What am I afraid of? My first thought is feelings. They may bury me alive. I think there are many emotions housed in this body. As I write this, I feel my throat tightening, and vivid memories of my work as a palliative care nurse lay in the background of my consciousness. Following these memories, I recall the many times I have participated in the processional walk when someone dies at the hospice. With 2 funeral home representatives, a few colleagues, and family of the deceased, we escort their loved one's body out of the building and into the back of a van to be driven away. It is usually preceded by lighting a 24-hour candle in honor of a life lived. Also, a member of the hospice team acts as a witness as the funeral home representatives transfer this person's body from the bed to the stretcher and into a body bag. We are there to ensure that respect is maintained all the way through that person's stay, even after death. When the transfer is done, and just before wheeling the stretcher into the hall to join the family, we place a blanket over the bag, and then we walk. Slowly and mostly quietly we walk, although at times tears become sobs of grief that can overtake the hall. Sometimes, as family members walk, There's a gentle embrace between them. Sometimes staff walk alongside family, holding them so they can gently take the next step. It's in these moments that I too can be full of great emotion. However, the rules are clear. As a healthcare professional, you cannot cry more than those you are serving. So I stop the emotion from finding its way out. I say, I'll take care of this later, acknowledging that I've been affected. Yet, with each covering of a body, lighting of a candle, and walk through the building, I feel that things are accumulating in my throat. Soon the rubber band will snap, and then where will I be? The first response of the first reader, which was my professor at the time, suggested perhaps I should just write these things in private. And that really struck me as a message that's very common socially, culturally, and even within our palliative care world, that the space for these big emotions and to talk about them, they're on the margins. So that response made me want to commit even further to going into these stories of complexity. And that story is embedded in a book that's soon coming out of this research study with 9 palliative care nurses. And it's alongside their stories, 30 stories in the book of palliative care nursing work. And all the quotes you see here are from the nurses themselves and the things they were encountering. So it was an opportunity to turn further in the direction of the discomfort and to explore, how do we do this work and how might contemplative practices help? So I want to pause there if there's anything arising for you as we go along. I know that was a big story to begin with. So I'm very grateful for the generosity and courage of the 9 nurses who shared their experiences, and you'll see their words continually being integrated here. And also want to just acknowledge my supervisors who stayed with me for many years through this work, Anne Bruce at the University of Victoria and Christine McPherson at the University of Ottawa. I don't see anything coming in. Okay.
Oh, there's nothing yet, Lacey, but thank you so much for sharing that. That was beautiful. And I think it's so important, right, to hear your voice, to make everyone, or to help everyone feel hopefully a little more comfortable sharing their voice.
Yeah, and there's another reason for story is there's the personal experience, but what I learned is there's a lot of other layers at play in our stories. And as I looked at this one with another lens, a sociological lens, a cultural lens, we have rituals and habits that are meant to support the grieving process. And then at the same time, I found some questions arising. Can they become mechanisms to hide behind? What kind of other rituals might be needed for myself anyways in that moment. And everyone has different things that catch them. I just want to invite some further conversation about that this evening.
Yeah, I love that wondering. There are a couple of comments now. So someone has said, powerful words, thank you. And someone else has said, I agree, it was beautiful. Thank you, Lacey. So yeah. Oh, and here's another one. It brought back vivid memories. I have also walked that hall with families and patients we've cared for, such a tribute and honoring. Mm-hmm. And another comment saying, thank you, Lacey, very powerful. I could relate to your story very much.
Yeah, and I can imagine many, that there's many layers of stories that arise in different directions for people. And here in this contemplative tree, which is about 20 years old, from the Center for Contemplative Mind and Society, they offer these variations and practices. And this isn't a fulsome list. There could be others, but you'll see storytellings embedded in it, which offers an opportunity to really develop relational ways and dialogue and listening. And you'll see some other practices we'll try out tonight, like compassion practices and meditation with breath. And in the links that you'll receive after, the Mind also has an empty tree for people to consider, what might be in your tree that supports you to ground yourself in the midst of various work that you do. And they also give a bit of a description of what are these contemplative practices and what are they about. And the first thing I'll mention here is it cultivates a critical first person focus. And even though it's critical, meaning you can turn back on yourself, it's compassionate to see yourself and maybe in new ways, and that it can be in that way practical, radical, transformative. It can support developing communication skills, focus, attention, and a compassionate approach to life. It can also help to aid in exploring the meaning and purpose and values that we hold dear. And so throughout this rest of this time, I'd like to offer you an invitation to think about what's in your tree, what are in your branches, what supports your relational ways of being, and maybe hopefully you might find new ways or share yours so others can develop as well through that. And as we think about what we value, one of the ththings I value more and more is the opportunity to pause. And that's another thing that contemplative ways and practices offer. And Pema Chodron, she's a Buddhist teacher. She says, every time we pause and stay present with the underlying energy, we begin to open ourselves to refreshing new possibilities. And so throughout, we'll just have some pausing, so some moments to pause. And this time I'd like to invite a pause with writing. And I'll give you a few instructions and we'll spend about 5 minutes, and you can really explore what your values are in palliative care, what matters to you. And this is like a free writing exercise. The Greater Good Science Center, there's a link in here. When you get the PowerPoint, you can go to it, and writing in this kind of way can support people across the education system and going through learning and teaching. And also for palliative care practitioners, I believe it's been helpful for me. In a few moments, I'm going to give you a prompt to choose from, or you can create your own prompt, and it's really just to help you enter into the writing. And then once you're in the prompt and you start writing, the idea is to just see what happens, to write whatever comes, not to think about it, not to judge it, not to go back and edit it, which is something I have a hard time with sometimes, but to just go forward. And even you might not stay on the prompt, you might find yourself off, and that's okay too, in another direction. And if you find yourself stopping, I've stopped, or rewrite the prompt and see what arises again. Try and find some way to keep the pen moving. You may want to use technology, and there also is some research that when you write by hand, it supports a different expression and connection within you. So we're going to spend 5 minutes. Is there any questions about those guiding ways in terms of this process?
Not questions yet, Lacey.
Okay, so we will, if you want to choose a prompt here, and I'll set the timer for 5 minutes and just see where you go. Palliative and hospice care is, what palliative care means to me is, or sometimes our values can very much show up in writing through a story. So an experience from my practice is, sure, I can go back to the guiding principles for a moment. And these are all drawn from the Greater Good Science Center. Any questions about them? Okay, thanks, Ed. And you may want to choose some other way into your writing. So I'm going to set the timer now, and I'll just ring this bell here. And may you enjoy this moment of pause with yourself to reflect on your work. I want to finish your last few words there. Okay. So the next thing we're going to do is try to share with one another what arose, what matters to us, each one of us, in relation to palliative and hospice care. So if you want to look through your writing, and maybe there's a 1 to 3 words that really stand out as being central to what you value in this work. Or they might come now, and invite you to go to, we're going to do a word cloud and really look together at what are all these ways we think about the work we do. And so you can do that in 3 ways. The first one is to copy and paste that pollev.com, etc., and go in and put your name in and then add your own words. Or you can text 37607 and then you have to put in this Lacey White 226, and then you'll be able to put your words in there. Or you can just put them in the chat, and Carl and Tara will help with that. And I will put up the word cloud so we can see what words begin to come through. Beautiful. And as those words are coming through, I want to share that in my own nerves, to begin speaking, usually when we do these writing practices, we start with a bit of a centering. So I would have liked to just invited you to find a comfortable way to note your breath for a few moments, and that helps to kind of center as you begin the writing. So just to note that's often the way. Carl, you have lots of work to do there with all the words coming through the chat box.
Yeah.
Yeah, maybe we won't be able to fully see it in the cloud.
Oh, I'll get them all.
Yeah, I'll get them. So let's just watch them come in, and so when the words get bigger, it's because there's more than one expression of the same. It's interesting how when they move around, the words that come together start to take on new meaning as I watch that. Oh, did I do enough? Thank you, Beverly. That's an evocative question as I read it through there. Ways to stop the intrusion into the sacred space of dying. How do we create that space where it's really open? Open and into the unknown, as Josie is saying there. I'm just kind of reading through some of them as they. My heart becomes very, very warm reading through all of the ways. Me and my drum, Mary, that's an interesting one too. One word I don't see up there yet, which is often, like, you know, central in our defining way, is compassion. But maybe it's because not dying alone. Okay. Proper mouth care, Jennifer. Thank you. There's, you know, we've got the uncertainty that existential realm, and then the very, very physical care that's just so important. So lots around emotions. eye and physical contact, touch, sense. So beautiful. So go gentle into that good night. And that, Dan, thank you for that. And we'll have some conversation a little bit later. I'll plant the seed here. You know, do you have any sense of good deaths or bad deaths? Like, what does that conjure up when you hear that? Dignity, honor, scary. Oh, so it's pretty remarkable. All of what you've offered through your writing. Does anyone want to share anything about the writing experience before we go forward? I wish we could dwell on each one of these, Lindsay. I want them to have dignity, to have the freedom to do what they want. If you want a cheeseburger and a cigar and a glass of wine, why not? Yeah. So when we talk about holistic, and we think about, like, if we were really to include it all, this is significant work, keeping in the moment in the midst of all of this that's arising and that we value and that we want to bring forward in the way in which we do the work, and the questions that are arising. You know, did I do enough? So our own humanity and all of that. I'm going to stop the cloud. And keep moving along. Thank you, everyone.
The cloud was full, so that was amazing. There was so much feedback that we filled up the cloud.
Yeah. I'll send that, and you can send it along, Carl, with everything else.
There were a couple of other comments just in the chat, Lacey.
Yeah.
About the writing process. Somebody mentioned that it was great. Somebody else mentioned their experience made me an advocate for advance requests for MAID. So that's not about the process, but yeah.
Yeah. And so what we encounter and how it shapes our next moments and the way in which we see our work and the way in which we engage with our work. So thank you for that comment. I really do wish to tell me more, but we do have that barrier in terms of text for now. These are some of the things that are often common. I think dignity and respect. I mean, there were so many. So this is such a limited list when we think about it in comparison to all that you offered. Often we are trying to close dualities, like it's not dying, it's living and dying. So we're bringing those together. How do we provide individual, unique care to each person and family? To be patient and family centered is often how we think of holistic care. And also, I'm pretty sure I saw in the cloud team. If I didn't, I think that came through in some way or another. But the list goes on and on as you showed. And in the traditional, the big definition we often go back to, the palliative care approach from a World Health Organization perspective, the two ways that holistic practice comes through there is that patient and family centered, and then also the view beyond pain, the physical symptoms and relieving suffering in that realm, but thinking also about the psychosocial and the spiritual. So I'm going to share a few other perspectives on holistic reflections. And I heard one good mentor and friend once say, are we putting too much in I'm paraphrasing now, but is it too much to imagine us to be fully holistic? There's a lot of tensions that we have to navigate that really limit our ability to maybe embody these values that we have. Financial constraints, less and less money within our programs, or stretched thin with staffing shortages. Because of that, often a focus on task-based care over that emotional, the psychosocial, the existential. And then there's the technology that comes in, and that the medical versus that not fixing and cure, that kind of tension between curative and really these other approaches. And one of the nurses from the study talked about wanting to provide wholesome support, not just needle medicine, and really feeling like more and more that's what their work was becoming, even though they had these intentions toward mindfulness, towards that presence, towards that way of being in the midst of the technical care that they were providing. So I imagine if we took a moment to pause here, you would add to your list around this. There might be ways that organizational settings are supporting those values, and then there are ways that it's difficult to enact them. I'm going to rely here as we go a bit further on some quotes, because this isn't my area of specialty, but I think it's really important that we think about looking at palliative care from a wider lens. So we often do kind of live here in that individual patient family or the biopsychosocial model, but in a socio-ecological conceptual framework that Nelson and colleagues there at the John Hopkins and colleagues across Nelson's in the School of Nursing, but also the Department of Medicine and the Department of Health and Behavior. They were wanting to expand our frames of reference so that there could be more equity in the way in which palliative care is provided, and suggesting that in order to support those individualized patient-specific needs, there needs to be a broader lens from other levels, so organizational, community, and policy levels. And I'll quote them here. They spoke about the crux of palliative care is providing holistic, in quotations, care for patients, but holism may be a misnomer given the breadth of inequities that exist. As it stands, this figure provides a visual representation of how the biopsychosocial spiritual model is challenged by systems it works within. So another invitation here, where do you, when you think of holism, what bubbles are you most drawn to? Where might we acknowledge for ourselves and in our communities of practice within the places we care, expand our circles to see other layers at play affecting the ability to provide individualized care for all people with social justice and equity. And I'm wanting to get to the point to share with you that contemplative practices can also, in the tree actually, there was a limb that talked about social justice activities. And there's often this perception that if we turn inward to focus on these kind of practices, that we're moving away from the actions outward, but they really inform one another. And I'm wanting to speak into that. But first, setting the stage a little bit to say that there are some inequities in the palliative care services across our country and elsewhere.
Lacey, as people are considering their bubbles, there's a comment in the chat box if you'd like me to read it out.
Sure, yeah.
Okay, so someone has shared that they have a personal definition of palliative care that's different than the World Health Organization definition. So they're suggesting palliative care, well, not they're suggesting, they're sharing that palliative care is not a practice for me. It is just a lifestyle that we have to practice every time, every moment with ourselves, with our families, with our other persons. It's about kindness, restore and provide dignity, care with love and passion, and try your best to be a humble and nice person toward all creatures. Palliative care teaches us how to deeply reflect on ourselves, understand our actions and behaviors, and do things with love and compassion. It gives the opportunity to put ourselves in the shoes of others. Then it takes us to the world of soul and returns us refreshed with excellent mood to live this beautiful life. It teaches us how to be more optimistic.
Beautiful, and it really reflects that inward and outward, how one relationships within ourselves and bringing that love and compassion within, and then outward, and they really inform one another, or can.
Absolutely.
Yeah.
Yeah, there's another comment. I believe we need to pay more attention to the spiritual component, not religious, of care.
Thank you. Yes. Beautiful. So what might be possible within your work to bring that forward and noticing that gap, so that that can aim towards that holistic way, and nurses from the study that I did really reflected that as well, that that was slowly being taken away because of the demands of the work and the restraints, financially and policy-based, is another reason. And I'd be curious to ask more about, why do you think that is there? So I'll move forward. I found time's moving fast, really fast. Thinking about equity in palliative care, there was a wonderful evening series here before this one around health equity and cultural responsiveness with Aaron Beckwell. So I just wanted to reflect back there and go back to Kelly Stajahar's article that Aaron spoke to. And she suggests, Kelly, that in terms of caring for people who are vulnerable due to structural conditions, that when services such as grief and bereavement counseling are formalized and professionalized, when care systems are routinized and bureaucratized, when whole person care becomes equated with pain and symptom management, research becomes obsessed with randomized control trials, big data and measurement, those people who hold less privilege become harder to see and also punctuate how much our current palliative care services are beginning to look like prevailing biomedical imperative in healthcare. And I just wanted to offer that because I think, although I'm not currently in practice, that a lot of this holds true, and I wonder how others feel in their own work. Nelson, from that model that I showed, and their colleagues suggest that as palliative care providers, we need to consider our blind spots. We cannot call the care we provide holistic if we're ignoring the systemic racism, the discrimination, the traumas that many individuals are encountering. And that's the link that I'd like to make with contemplative practices. And Rhonda McGee is a lawyer and draws contemplative teachings into the work that she does as an educator in law schools to humanize the education process, to think about policy, and really believes that these contemplative practices can support that reflexivity, that self-awareness, to really notice these blind spots, notice habit patterns, to develop a capacity to be with tension and uncertainty and complexity, and to really lean in and transform. And also to bridge the dichotomies that can happen, to think about both and how we can bring things together in a more holistic way, so to speak. Sounds like it looks like there might be a question here.
So there's a comment. It says, like, reflecting on the definition that I read previously, the person has shared that she'd like to suggest palliative care, like mindfulness, is often wordless. Its mysterious nature often becomes simply presence, which is open for all who are involved, regardless of options, access, and clinical setting. Just be. This is bigger than all of the other dimensions. Still process and worry that I missed something.
I don't think I said it at the very beginning, but I really wanted to invite diversity of thought and perspectives, and I'm not sure if we can get to the defining way, and there are these many ways, and can we bring them together? Can we have conversation? Can we expand our perspectives and create that space for the love and compassion and the technical aspects that we see the person who needs mouth care? How do we, and also the policy that might be really impacting the way in which we provide care. And I'm really grateful for a colleague here who at the provincial level, palliative care nurse at the provincial level, and I are speaking and trying to live within that tension of how do you create these comprehensive individualized care plans for people to meet people where they are, and then also in some way standardize that at a policy level. And is it even possible, and how might we do that? And if you have any good examples of care plans, I'm going to put in a little tiny plug there, please send them along. But there's a lot to consider in this work, and I'm grateful to be here with all of you and hearing your perspectives. And it's mysterious, and it is wordless. How do we actually convey it? And I think that's where stories can be quite powerful. one of the things that I've been learning since I've been in Cape Breton is that in Mi'kma'ki, there's no word for pain. And that really struck me and made me think more again about the patterns and habits, what I've learned about how to do pain assessments and what actually that might mean if I do that with all people, because it's a standard assessment that we do. And as in Truth and Reconciliation, being all treaty people who share responsibility for taking action on reconciliation, I'm now curious how I might unlearn some habits and maintain an openness for other ways, and to have conversation around that. And again, contemplative work, contemplative practices can offer that ability to create awareness, to see those habits and to pause and to step back and to open to maybe a new step along the way. Just want to also share that not too far from where you are in Montreal, if you haven't heard of it, there's the Whole Person Care Program, who's Tom Hutchinson and others are offering. And that's both to support the dignity and respect of each person as a whole person, but also to honor the wholeness of the practitioners themselves. And one of the nurses in the mindfulness study that I did said, if we're going to do whole person care, we also have to pay attention to our own whole person, all the damaged bits, the growing bits, all of it. We're gonna jump into another hopeful pause here. And before we do that, I want to offer some space for any other reflections that might be coming in before we transition from that kind of content.
There's a question, Lacey. Will we be discussing practices to help nurses coming onto shift to become present and leave their worries outside the doors of our clients?
Excellent. Well, thank you for that question. And like the tree, I don't think there's a prescriptive way for any of these practices. It's what works for you. And some of the nurses that I spoke with, they had these practices that they did. They had a fountain they looked at. I think I'm trying to remember some of it that didn't make it in. But what works for you? Or even there's the one nurse walked to work. May I be of help? May I be of service? And have this mantra that she kind of, to get herself into that mode as she gets to work. And then there's also those practices of what you do even before you go into a room. So there's the getting into the hospice, and there's entering each person and family room, which also may require you to take different shapes. So what supports that? The breath can be one of them, and that's the one we're going to do here. But there also might be other anchors. So there's the letting it go, but there's also being human. So I'm curious about the leaving it all behind. Is it always possible? Can we notice when we can't? Can we notice if what we take in is impacting our relationships with others? And then also, some people use music. Some people, there's lots of different ways. So part of the offering is for you to consider for yourself what works and to try on a few things.
Thanks, Lacey. And there's another comment. Someone has shared that their job, there's now an end-of-life care plan for residents who are receiving palliative care, and it's helping. She's sharing that's helping her become a better PSW.
Excellent. I'd love to see how that's brought into action, and how something that's a bit formalized can also support being with people in unique ways and really honoring each person and family.
Yeah. And there's another comment now. I think you're completely right about our palliative and hospice care systems being largely blind to the marginalized and vulnerable. Perhaps another approach is to build more space for reflective practices by and among the healthcare practitioners to reflect on what's happening. Then they and others act, speak, feel, and share their reflections.
Excellent. Thank you so much for that, Dan. And it really does speak into something I have in a close to the end of the slides, actually. Where are our space for these conversations, for these feelings, to navigate, to have conversation together, to consider and create a creative imagination for other ways. And even not just energetic, emotional space, but physical spaces. Like one of the nurses that spoke to me shared how they lost even kind of a place to gather. There wasn't an office for that private ability to talk through things. And sometimes, although the debriefing and the formalized debriefing can be helpful, sometimes depending on the situation, and these kind of conversations can be full of tension, and we want to make sure the space is safe. And these contemplative ways can hopefully offer a container to invite that tension in and to work within ourselves and with one another. How about we try the breathing practice now? And so you have an opportunity for a different voice. The person who leads this 3-minute breathing space is Jon Kabat-Zinn, and he's known as the founder of the mindfulness-based stress reduction movement. And we'll just find a comfortable spot and have a listen.
In step 1 of the breathing space, becoming aware of the present moment in its fullness. By deliberately adopting an erect and dignified posture, whether sitting or standing, allowing your eyes to close if that is possible or appropriate in this moment, otherwise keeping them open. And in either case, resting in an awareness of your inner experience, opening to it and asking, what is my experience right now? What thoughts are going through the mind? As best you can, noting thoughts as mental events, perhaps even becoming aware of their content in words. What feelings are here? Turning towards and opening to any sense of emotional discomfort or unpleasant feelings. What body sensations are here right now? Perhaps quickly scanning the body to pick up on any sensations of tightness or bracing. Now in step 2, gathering and redirecting your attention to focus on the physical sensations of the breath, just breathing itself. Moving in close to the sense of the breath in the belly, feeling the sensations in the abdominal wall as it expands with each in-breath and falls back with each out-breath. With full awareness following the breath all the way in and all the way out, using the breathing itself to anchor you in the present moment. And now, in step 3, expanding the field of awareness around your breathing so that in addition to the sensations of the breath, it includes a sense of the body as a whole, your posture and your facial expression, how they feel from the inside. If you become aware of any sensations of discomfort, tension, or resistance, experimenting gently with breathing into them on the in-breath and breathing out from them on the out-breath. Perhaps feeling a softening and releasing with each out-breath. If you care to, perhaps saying to yourself on the out-breath, it's already here. Whatever it is, it's already here. Let me feel it. And now, as best you can, bringing this expanded, more spacious and accepting awareness to the next moments of your day, whatever circumstances you find yourself in, as it continues to unfold.
Okay. Thank you for joining me with that. So the breath is often considered an anchor point or a way to find our center in the midst of things. And this quote from Thich Nhat Hanh speaks to that line. Feelings come and go like clouds in a windy sky. Conscious breathing is my anchor. I chose Jon Kabat-Zinn's audio here also because he is noted to really have brought that mindfulness-based stress reduction program, an 8-week program, forward and into many areas. And the whole person care program that I showed a few slides back, they have adapted it to mindfulness-based medical practice. At the same time, his book that brings that information to us and what's in that program is called Full Catastrophe Living, Using the Wisdom of Your Body and Mind to Face Stress, Pain, and Illness. It isn't necessarily about, getting rid of all the stress. Life has these things. We know as palliative care, there's beautiful love and privilege and such a deep richness to the work. And it's not easy, and there is a lot of other things that arise. I also want to share here that one of the nurses offered in reflection to me. She was telling a story and she had her hand on her chest, and I had noticed another nurse tell a story, and as she was speaking she had her hand on her chest, which I learned later is a way to provide soothing touch and can really support that connection between mind and body. But I asked her, is there a reason why you gesture here to your chest as you speak through this story? And she said, I do find that one of my things is, I think I have some chronic pain related to it, because the longest time, I don't think I was breathing into my chest. I don't think we are teaching this in nursing school. I'd like to ask the other disciplines if you were learning that in school, because when we're with people in pain and with big emotions and things like that, we naturally hold it up here. So how do we maybe use our breath and invite it into the spaces of our body to be open and in our own whole selves as we're with others and trying to provide whole person care to others. I also want to bring forward a text or a teaching from David Treleaven and others, who suggests that the breath is not always a neutral anchor. So we think the breath is, when we're in trouble, let's just focus on the breath. But the respiratory system is connected to the nervous system. And if there's a big sympathetic response, trauma response, it can actually not be helpful, that another anchor might be better. And so some examples from the nurses in the study that I did, one nurse offered this image. She was in the medication room and she said she imagined her feet in the sand on the beach. And another nurse talked about going to the garden at the hospice and to smell the flowers and to hear the birds. And sometimes just going to a different sense can be helpful. So what works for you, and to try these out in your own time. I think the reason I really came in to study this further is because I was doing these contemplative practices and ritual and yoga and meditation and studying Eastern philosophy and these compassionate practices. And at the same time, was finding it very difficult. And there's a whole body of research happening now, oh, sorry about that, that really looks at what are some of the challenges that people can encounter when they do start to meditate or do other practices such as these, because we are inviting ourselves to turn towards our experience inside, which might not always be comfortable. So I offer this as for people who are interested, for people that want to think more about the safety issues, the trauma-informed lens around contemplative practices themselves. On this website, the main researchers, Britton and Lindahl, they offer a meditation safety toolbox to think more about how do we bring these practices in, share them with others, but also for ourselves in ways that help us to ground and not actually create these dysregulations within our body. And thinking back to a question a little bit earlier, how do we leave what we have behind as we enter into the hospice? I think the other side of that question is, how do we work in a way that things don't pile up? So we're not carrying so much every time we go in, whether that's personal or professional, but we know professionally that things pile up. This was an image, and I finished my work on this inquiry and this writing just as the pandemic was beginning, and it was very humbling to really be studying how to be with grief and with loss and with suffering, and then to see the magnitude of it really just when the pandemic began and onward. So we know I hope you're all well. I hope you're all taking good care and receiving support. And we know that there's lots of questions right now of how to support healthcare providers and the work that they do, so that it doesn't get stuck in the body. I'm not going with my notes here, so I have to find my next story here. I invite you to listen to another story. And as you listen, just first notice what arises for you, just what's there. And then also afterwards, we'll reflect on what does this story maybe have to do with holistic care. It would have touched your soul. Her brother and son stayed at her bedside for 48 hours. An extremely strong woman, not wanting to let go, but having to let go. She was moaning, almost sighing, crying as she was taking her last breaths. And this went on for a couple hours of having her doing this, and her brother and son crying over her, holding her hand. It was heart-wrenching. And so trying to breathe as I'm standing at the door. And yeah, I did shed a tear. I was so heavy of grief and love all at the same time in that room. It's just, you've got to keep breathing to get through, because it's touching. And if you didn't feel anything, I'd be worried as a caregiver, because it was horribly sad. And there was so much love in that room at the same time. So it's just keep breathing, swimming, just keep breathing over and over. Having myself ready and in check, asking the family, would you like this for her? Do you feel she's in pain? Do you feel that she's uncomfortable? Would you like this? Doing those checks, those very sterile nursing checks in your head to keep yourself going and flowing through what you're needed to be. That's another one from the study, and invite any reflections on first thoughts or first feelings. How does holism come through or not, maybe in the story? For me, one of the things that strikes me as she first talks, and someone said with that spiritual part of this work, she said it would touch your soul. It's connected at that level. And then heart-wrenching, she's connected with that felt sense in her body. And then those sterile nursing checks. So we also know our evidence-informed practices, our guidelines, and the ways in which we work to provide that competent, skill-based care. And another way that this story really takes on a holistic form for me is how it actually came into being, this story. And in the conversation with her, we were going back and forth, and she shared at points her aim to really focus on the other, you know, like that previous perspective on, you know, leaving the things I've got going on behind and going in to be of service to others. But then she also shared the impact, and that this is hard and that she needs to care for herself. So I asked her, I said, I'm struggling to find a question that's not so theoretical. Like what's between that care of other and care of self? What's going on there? And she said, well, let me help you with a story. So that's the story. And I think that's another holistic lens we can put on things. And we have this tendency to want to break things apart and make them dualistic. So there's the self-care or the care of the other, but can they coexist? So I see some comments coming in.
You want me to read them out, Lacey?
Sure. I've lost track a little bit of where the chat begins and ends there.
The first is a question. Why would a nurse, doctor, PSW let someone passing in such discomfort not take action for comfort?
Thank you for that question. That's a really important question. And I'd like to hold that one open for that question around good deaths and bad deaths. And you know, that nurse, like, why wouldn't we want to support people in the best way forward towards you know, a deeply meaningful experience and quality of life. So let's talk more about that in a few moments.
Sounds good. There's a comment, trying to be supportive, compassionate, and caring while witnessing family pain and journey.
Yeah. So there's that again, that link between caring for the person who's dying and then also reflecting on the family and the family's pain. And there's research now that shows, when we think about, I mean, I think everything, put it all in terms of holism, but I'm trying to give these different angles. But another angle is across time and trajectory. We know that families that are supported throughout the caregiving process and that time of living, dying, and the bereavement phase, if they're not supported, that bereavement can become even more complex. So really trying to honor their needs at the same time.
Thanks, Lacey. So important. Yeah, the next comment is, the waves resonated for me as during the writing exercise, I wrote navigating the waves that invariably rise and fall for both the family and caregivers.
Thank you, Cindy. And for the nurse, you know, she's in those waves with them to some degree. And you know, how calm or fulsome are those waves in terms of where they're taking us.
Okay, and another,
how to be anchored. And there's the anchor you can put into that wave metaphor.
Yeah, totally. So here's another comment. I'm sad to say that I do not think support for healthcare workers comes from healthcare administration. It seems that we need to find our own personal practice to care for ourselves as more demands are placed. Yeah, and going back to that socio-ecological model, can we make some gains there, and how might we, in order for us to do this work well, can we be held to hold the other? I think of my first mentor in hospice and palliative care, and Marin, where I was working, and I asked her one day, do you miss the bedside? I couldn't imagine her being in a role like hers. And she shared, health is on a continuum. I take care of you and you take care of them. And that struck me, and it stays with me, because I'm not currently in a clinical practice. So I really want to go back soon in some capacity. But so I think about that in terms of the nursing students that I'm providing education for, but how do we care for one another? Because doing that, we know will offer, it will take shape and support the work that we're doing with others. Absolutely. And Cindy just clarified her comment earlier about family.
Thanks.
Yeah, that the caregiver, as she was referring to the nurse.
Thank you, Cindy. Yeah, I missed the voice part of it all. I thank you all for having this text conversation here, and it's going pretty well. As I was a bit nervous about it. So drawing on a psychotherapist, somatic psychotherapist, trauma informed, they talk about the precursor for holistic functioning is the synergistic functioning at the cognitive, emotional, and the sensomotor levels. And motor might be think about that as like the felt sense, or that aching heart, those parts that we literally feel in our body. That a phrase coming from one of the nurses in the study is the heart, my heart was in my boots. Like these very visceral reactions or responses within our body. And at the same time, thoughts and emotions, that's the language we usually use. We try and, this is emotional labor, but how often do we actually have that space, like in that breathing practice with John there, to both attend to our breath, but also that what's going on at that embodied level. And so Ogden and colleagues, their work is to create processes of integrating trauma experiences from the bottom up, from the body to the mind, or to the thinking mind. And right now, most of our ways in education and practice is top down. Also, when things are really hard in that or challenging in that emotional felt sense space, it's a habit pattern in body often to go towards thinking, to go toward the rational mind, to go towards the judging mind, which we want to be non-judgmental in palliative care, and we're human. So I also have heard in various ways from various people, like, there's still judgment. How do we create a space to see it, but not be, fully taken over by it? And so attending to that heart-wrenching part of our work might help.
Thanks, Lacey. Before you go on, can I just
Sure. Yeah.
Yeah, so Cindy had a little laugh about your comment, hard without the voice. It's all good. There's a comment from Dan. What do you think about palliative care in long-term care homes? Some presenters at these evenings have felt that most residents in long-term care should be receiving palliative care, given the morbidities that bring them to long-term care and the life expectancy of residents, but that is not the case.
Oh, it's another part of, we've known for a long time, but the pandemic is shining lights on particularly problematic issues within our society. And certainly the care of seniors in long-term care homes is one of them. And I think about palliative care here as an approach. It's a way of being. And I couldn't imagine another way of being with our seniors, with our elders who have offered so much in our world, who have so much wisdom. And again, what can we do to shift that? And I hope that as we go forward, there'll be some change, some collective change for that. I'm not sure. I'm rereading just to see if I really got what you were suggesting there or wanting to talk about there.
Yeah, I was also looking for, I wasn't sure too. So maybe it was in my reading if Dan is saying it's not the case that long-term care there should be a palliative approach in long-term care, or if he means that it's not the case that a palliative approach is being implemented.
Yeah, there's certainly, and actually I can send along a paper. I'm not sure, actually, I'm not sure if it's open access or not, but as I was preparing this presentation, and it's a little too far back last week, so I can't remember the first author's name, but there was one paper that I was kind of drawn in because they do use the term holistic, and they're talking about that in terms of care at long-term care, and also naming those institutional problems that are barriers to enacting that palliative care approach.
Yeah.
Thanks. Thank you for bringing that forward, though, and it's heartbreaking to think about what's been happening in long-term care homes, and also with family members in relation to visiting and being essential. So there's lots of complexity in that, and I'm glad you brought it up so we could just take a moment to really think about that.
Yes, there's another comment about long-term care, so I'll stick with that for now. So Beverly has said long-term care, they only seem to get involved when there is an end close at hand, as opposed to stepping in sooner for comfort. I have been spoken to spoken to, I guess, and not in a nice way.
Yeah.
So they step up for additional comfort.
Mm. Mm.
So
Yeah.
I was just saying, Dan has provided a little more information, and he's saying it's not the case that long-term care homes provide palliative care. The stats were something like less than 6% of residents receive palliative care.
Thank you, Dan. I'm wondering where your stats from, but I appreciate you bringing that, because it's true. There's just this huge gap. And thinking, Beverly, of your comment, and we know that a palliative approach is strengthened and deepened when there's that relational, when relationships can be honored and can begin sooner than later. So that sounds part of what you're speaking about there. Yeah. And I also, as your comment made me think of another part of a story where a nurse went after hours. She was done her work, and there was a young mother who was dying, and she went after work to sit with her. And I didn't comment it on the book, actually, but David Wright, who wrote the foreword, and some of you may know him from the University of Ottawa, I really appreciate that he circles to that story and says, he really questions, why is it that the nurse has to go after hours to provide that additional care? Why is that not in the structure of our work, honor, really respected?
There's so many comments here, Lacey. I'm trying to keep up. So Kenna shared the thought that in passing, people may enjoy hearing the favorite stories that they enjoyed telling in earlier times.
Mm-hmm. That storytelling is so powerful, and we'll get to a short slide on that. And that's the things that can't be measured, right? And we have so much of a focus on measurement in these institutions and organizations that are trying to be fiscally responsible. Maybe I'm not the best around these critical. What's the language here? But we have to find language and find ways to bridge that desire to be holistic at the bedside, and then also what does that mean, and what's influencing that at all these other layers.
So yeah, a couple more comments about long-term care. So someone has shared that there are times, however, when families of residents in long-term care who refuse a palliative approach. I think more and more long-term care is taking more of a palliative approach.
Yeah, and I think we should, so we don't run out of time, the video that we'll get to in a short while links back to a long-term care story. So I will, it might not fully respond to that reflection, but I think it'll add another layer to what you're offering there.
Perfect. Yeah. So the last comment is also, well, there's now two, but another reflection on that maybe families are afraid to admit palliative care is needed. And then a last comment, if we notice a resident is declining, we offer palliative care and long-term care. I noticed most of the families like the resident to be pain-free.
Mm-hmm.
So a lot of reflections here on palliative care and long-term care.
Yeah. And I will just, as I reflect on the family being afraid of maybe, and so it's true, socially, culturally, we haven't created a whole lot of spaces. Often there isn't, we haven't kind of created that way of dialogue. And at the same time, I think that us as healthcare professionals, do we have the capacity to invite those conversations, to go into those uncertain and just walk alongside someone in those conversations? And that requires a great big capacity. And when I say that, I think again of this embodied felt sense, to be able to feel into and with people through those conversations. So I think I'll go to the next slide here, because it's a nice transition to that felt sense part, and to go a little bit further about that and Ogden's model here. So this felt sense, there's this terminology called the window of tolerance. Like part of the aim in a trauma-informed way with contemplative practice is to support people to be in this kind of grounded state in the window of tolerance. and to start noticing when they're moving outside of that. And want to ask you, do you have signals within your own body where you're like, I might be getting a little off, you know, a little, I might need to go and find a practice for myself, or find a way. Maybe that's a cup of tea in the staff room, if you have one, if you're happy to have one. When people are outside of the window of tolerance, it can lead to hyper arousal states where there's this increased sense of sensation. The shoulders get really tight. Maybe for me, it's that, you know, that tightness in the throat as I'm kind of holding back emotion. This hypervigilance, having these intrusive, the story just keeps coming back and back. There's hard to sleep. And some of the things that nurses shared is, I felt my adrenaline really high. It kept going. So there's a sympathetic response, a stress that's deep in cortisol, the heart rate gets fast, the breath gets fast. And on the other side of that is thinking back to that story of the nurse that's swimming and breathing. I'd be worried as a caregiver if I didn't feel anything. So is there this numbing of experience in the body? And there's this really excellent paper by Back and colleagues, and that's a physician, and he works alongside Cinda Rushton, who wrote Moral Resilience and is a contemplative scholar and practitioner, and Joan Halifax. And they, instead of talking about arousal states, they talk about engagement states and the somatic cues. So again, going into the body, this when someone's hyper engaged, they'll feel that tenseness in their body, or the heart rate, or the churning stomach. And also this hypervigilance. I need to fix this. And so in palliative care, we're trying to minimize that need to really kind of overdo or fix this situation, and to really honor what's there. And then on the other side with these somatic cues is if there's this, so that's when people are kind of getting really, really involved with others. And then there can be this hypo engagement where people withdraw. And I've noticed that also in various clinical settings where, you know, so-and-so in room number, whatever, or with this diagnosis. And probably that's a conversation you've had before, where we kind of separate ourselves from the sense of who that person is. It can be a subtle and not so subtle way of disengaging. The idea is, can we notice our signals, our somatic cues sooner, and then be able to find practices that work to ground us? So to go into a different metaphor, I think that I just heard a sound where you're going to offer some question there. Nope. Is there something?
Not sure. I will.
Okay. So I'll go a little bit further, and then we can go back to the chat and see if there's anything there. So if we go back to this idea of hyperarousal and hypoarousal, is what supports you to kind of feel the waves, to be within the waves, but not really going on this big up and down sailing adventure, but having that smooth sailing experience. And I gave a link here to this resource, and within it, it also has a little bit of a description of that 3-minute breathing space, and references Ogden, and it's open access, it's free, and it's developed by the Mindfulness Awareness Ability Training Program through the Unity Health in Toronto. So what are your triggers? Does anyone have a sense of like what might take them off balance? I'm going to go into another story, and there's a bit of someone not having enough time. Yeah, thank you, Josie. When we're moving so fast that we're not able to really kind of settle into, and I feel that when I speak, when I was at the beginning, and maybe a little bit now, but not as much, where I kind of moved over top of my intention towards centering before the writing, moving too fast. And we do that when we feel like we have this poverty of time. Metrics over quality. When the client is my age, yeah, thank you for that. When there's some kind of reflection from someone you're caring for, or a family member, that links with something personal, that can be a real place of exploration and inquiry, and to just notice, and to be really aware, and and to maybe even at times, if you notice it's coming up and maybe taking you too far afield into those various arousal states where you might be over-engaged or removing oneself and then not really being in that relational space with people, is to call on the team if you have a team, or to take that moment to, the image is coming to mind of a nurse seeing a mentor just come out of a room and just lean against the hallway and just take a few breaths. Like, what is it for you? Yeah, family members who cry on your shoulder. I'm just looking at the comments here. I think I've lost a little bit of track of what's going on there. There's been a few stories, and I hope that as stories beget stories, that some of yours have come to mind, and to be curious about that, you know, which arose and for what purpose, what memories come forward. They have something to share. There's wisdom in those stories, and to really respect them. Flashback memory of a family member dying in your presence. Yeah. Thank you, Maria. I wish to know more about that. Touch, the eye movement, especially above the COVID mask. So is that I'm wondering, is that I'm not sure I understand that particular comment. If you could share more about that. These offering, we go back to, if I go back to the comment about, do we have space for these conversations? Some of these stories are really big. Some of these experiences are really big. Who can we share them with? And can we share them with our colleagues? Maybe sometimes, depends. Do we have the space? Do we have the time? And as I was preparing this, I was thinking of Maurice Bouvette, who I'm sure many of you know. When I was there in Ottawa, I was at one of her talks, and she talked about this traffic light process that she had with some of her colleagues, which was, if my light is green, I'm open, I'm available to hear what's going on for you today. If it's yellow, you know, I might not I'm here, but I might, you know, might have to tread a bit lightly. And red is, you know, I've got too many of my own today, or is there a way that you can find support in another way? But how do we create these space to share with one another? Because we know that it can support that relational awareness. It can help integrate experience, to make sense of things, to feel that sense of connection and listening. And that's both for us with one another, and then also, as someone said, with the people we're caring for. So I'm going to share another story. Last one here. He just had surgery. He had some problems with it, and he had this really sore spot. This is a nurse speaking to me and telling it to me. He could hardly move, and the doctor was looking at him. His wife was sitting there, and he was calling out because it hurt so badly to move. I was almost in tears because I felt so bad for him. I thought, oh, it hurt. And then I realized I've known him for a few months. His wife's sitting here. How hard is it for her? So I just reached over and I held her hand while he was bouncing and groaning, and she started to cry. She probably wouldn't have cried if I had held her hand, if I hadn't held her hand, but I thought, she needs to know that I recognize that this is hard for you to sit here. I think she needed that too, just that recognition, because that was really hard. But again, I was caught up in the moment thinking how hard it was to watch him. And then I realized, wow, put it in perspective. I've only known him for a little while, and this is his wife. So she knew I cared that way. You know, I didn't have to say anything. She knew. The reason I tell that story is because it links really well with this definition of mindfulness from Arjan Amaro. And he wrote this paper in 2015, and he comes from a Buddhist lens. And I actually met him at a conference one day, and I was feeling like, is it okay to use this definition and not to necessarily put it with the rest of the theory of the Buddhist reflections and conceptual ideas that he was offering in that paper. But I really like this holistic mindfulness being unentangled participation in the field of all experience. So if we get tangled up, it might take us a little off and narrow our view. And the way nurses spoke about their experiences, they used words like caught or trigger or unravel. So it really linked very well. So I think it's a good language to help play within our stories, to notice where we're caught up, to notice in the moment where we might be kind of feeling drawn in one direction. How to respond when words won't come and all that one can observe are the eyes above the mask. Yeah, thank you for extending that further. How to respond when the words won't come and all that one can do is with the eyes. How to be present for others, including colleagues.
Lacey, I don't know if now is a good time to go back, but there were a couple of other things in the chat box.
Sure.
Okay. So there was a comment someone shared when they worked in hospice. Their young teenage son asked one day, "What's a good day at work for you? Is it when someone dies or no one dies?"
Aww.
Yeah. And then
how do you respond to that, Carolyn?
Just what a thoughtful thing, right?
Yeah.
That's pretty amazing. And then there was a comment earlier, a story that was shared. So it says, in relation to Ken's comment above, read favorite stories and related to the nurse who went back, maybe she simply wanted to. We had a student in the past who was an excellent violinist and became aware of a patient in the ER who was with no bed available and lay dying on a stretcher. Loved fiddle music and particular songs. The student nurse went home after practice and came back in her street clothes and played the violin to him with songs he loved, and he passed during this. She did not share this with me, but the nursing staff did. Now that is caring and compassion and empathy and love and genuine giving soul.
Oh. Thank you for taking the time to write out that story. It's I'm saying story, but these are experiences. They're deeply felt and they're in the moment, and they're well, this one, there's so much generosity in it, and like you said of the other nurse who went back, we also do this work because we love it, and we go and she's some other things unfolded in that time when she went to sit with that young mother. And she said, you know, maybe I was there for her, but maybe I was also there for myself, and the exchange that ended up happening, and just trusting these flows. And absolutely don't want to minimize that great movement from within to go with that. And then also to call for administration and policy to allow for those spaces so that they're also included in the work that we do, so that it can become more and more a part of that holistic approach at a baseline. I think that, and it's not that either or, I think it's that contemplative practice of both and. How can we do both and make this space for transforming the palliative care work and reaching more people with authenticity and with that whole person sense, which truly that story conveys. Thank you for that. Rosemary, I'm also contemplating the masks and thinking, I haven't been in clinical practice having to wear a mask, and I certainly have heard and listened to some of the dialogue around that and how challenging that is. And then also, I mean, I would love to invite others to speak with Rosemary about that. And I'm thinking of a nurse who sits at the bedside and says, I'm just lightly breathing myself. This presence we can bring with our eyes, but also it's helpful with our being able to see our mouth. But I wonder what else we're able to convey, even if this is covered. But I can also see that limitation in the way in which communication's been unfolding for the last many years. The question about is, what's a good day if there was a death or not a death? And I'm wondering, does it depend on the kind of death? Do you have stories of a good death or a bad death? I'm just asking Carl here to put up the poll to just offer some moment of collective reflection on this. It's maybe not. I actually had taken the question out of the poll and put it back in and taken it out. I think it's a bit of a tricky question.
Yeah.
There's no
Interesting just to hear it quantified for sure.
Yeah, I really struggled with that, but I wanted to offer a moment to conjure up, like, when I say good death, what arises in your mind? When say bad death, what arises in your mind? Maybe that would have been better than a poll itself. We can just cancel that.
It's all good. I think.
Is there are there people? There's responses coming in.
Yeah, I think most people have responded here.
Oh, okay.
And,
I thought it wasn't going.
Oh no, it was going. It just there's the responses now. So
Okay.
it's like 32 people said yes, and 2 said no, and 9 said they're not sure. So
so that's curious, I mean, of course there's this resounding yes, and then to those who said yes, what does that mean, and who determines, what determines a good death? And for those who said no, I'm very curious about that. Well, what perspectives you have, and also appreciating those who are sitting in contemplation without those definitive responses. Seems like there's lots. Is there any in particular that
In terms of the comments, Lacey?
Yeah.
A few people have shared some of their experiences around good death or bad death. So the first comment was, I was comforting my siblings to accept that my dad is dying. We were not able to be with him in hospital because of COVID, but we communicated via chat with caregivers. It was traumatic to see his last breath. The next comment, good death is with no pain, unresponsive, bad death, patient suffering, eyes wide open, and trying to talk to God. Another comment here, I think my grandfather had the best death I could think of. He was in and out of hospital over his last few months for diabetes complications, but when he passed, he was at home. He ate supper with my grandmother, lay down on the couch to watch the news, fell asleep watching the news, and died in his sleep. I think that dying in the middle of a good nap after a nice supper with your spouse of 50 years is a pretty good way to go.
Before you, I'm lingering, particularly, on Maria's comment there, and just wanting to take a moment to feel that experience, and knowing that that's everyone's experience is unique, and that's such a shared experience through this time of COVID, where people are separated, and these deaths that people are experiencing. Thank you for sharing that, Maria, and also wanting to thank others for sharing their experiences as well here.
Absolutely.
I see there's a lot coming in. I think maybe I will read those through as maybe offer you the opportunity to watch this very short video which is a further reflection on good death and bad death.
Over the years, people have asked me, where do you want to die, Kath? And I think, I want to die in a bed of roses without the thorns. And then a few years ago, I bought this great bed for outdoors. And I said to my kids, here's the bed I want to die on. Outdoors, underneath the stars, life is good. But I think what they probably meant too is, what kind of a dying experience do I want to have? Because in some degree, I'm not sure that it matters to me where I die as much as how I'm cared for. So people often will think about a good death and what they mean by a good death, and they'll get disturbed if someone they care for doesn't have what they call a good death. And yet what we realize is that everybody's definition of a good death has its unique qualities, and some people's understanding of what would be a good death for them is very different than another person's. So some people, their definition of a bad death would be someone else's definition of a good death. Now, most of us are similar on some things. Most of us, if you put together a list of good death and bad death, most of us will say a good death includes being pain-free, symptom-free, feeling that you've had a life well lived. Those kind of things are probably pretty constant. But some people will say, I want to die alone. And some people will say, I want to die with my family. Some people will say, I want a quick death. And other people will say, I want time to know that I'm dying. And others will say, I'm going to need a good long time before I'm ready to die. And I'd like lots of warning. So what's on your list? What's on your list for a good death? What would make a good death for you? And similarly, what would make a bad death for you? And then when you think about it, and next time you're looking after someone who's dying, think about and talk with the person if it's appropriate and if they want to talk. What's a good death for them? So I've seen people in long-term care who have agonized because somebody was transferred in their last hours to acute care to be seen in emergency and died in emerge. You know, they felt that burden because they knew that person and could have provided beautiful care for that person. However, when they discussed and described that person and that person's life and their preferences, that person wanted acute intervention all along, throughout their life and even close to death, and the family wanted it. And so, though I can't say that it was a good death or a bad death, it's possible that it was a death that was appropriate for that person. And maybe it wasn't so bad for them. So looking at what people want, thinking about what you want, and helping people to talk about what they want may be a really good way to help us establish how can we provide care that will help this individual meet their needs. Thanks, that's Kath with Life and Death Matters.
That was Kath Murray. She's over there on the West Coast and has some very accessible texts, Life and Death Matters, for various disciplines, personal support and nurses in particular. Thank you for everyone who's offered comments in the margins, and I think in the chat there, I think that Kath spoke into a number of them, and because of time, I'm just going to summarize a few things that came to my mind as I was scrolling through them. And then as I do that, if there's anything else, please feel free. This seems like another topic in and of itself, a very rich conversation around this. One thing is that some cultures, and I'd like to study this more, but I learn again here in Mi'kmaq that there isn't a word for death. Different cultures have different perspectives on whether dying is happening, you know, what is that process, and is that the word? So even that, you know, makes me curious. I also read about that pain-free, and Kath spoke to that, and in again that Nelson article, it's a 4-page special report in the Journal of Palliative Medicine, but that was that call to action to address disparities. One of the things they write in there, which really struck me, because I've studied Advaita Vedanta and kind of Hindu perspectives, but traditional worldviews lend some Hindus to interpret suffering as a result of karma and a way to resolve actions, poor actions from a previous or current life. This may involve enduring pain despite availability of pharmacological interventions. It seemed like strong. I wanted to, there's one reference, I wanted to go and read the reference and go further and further. I think this is a whole area of study. But one of the nurses in the study said, as a hospice nurse, you can get caught up in the idea that everyone wants to be perfectly comfortable all the time, and a lot of people don't want to be. So being aware as a nurse, am I doing this for me or am I doing this for them? And I appreciated in the comments that someone spoke, you know, this good and bad death, it can come from our own perspectives on what we think is a good or bad death. And then the other side of that is what do people want? Have we prepared? Have we had the conversations? Have we got a sense of what that means to them? There's a really great practice Joan Halifax offers on another contemplative writing practice. What is your worst imagined fear of death? What is your best imagined death? And you write through that. And I've done it a couple times and done it in community. And it's very interesting to see how those perspectives are so different across our shared writing. And also for me, having done it over different periods of time over the years, how my own experience and perception of that changes. And so being aware of that can support us towards that whole person care, if we want to go back to that holistic link, in that if we're caught in a particular story about what it is, do we have the space to move in other ways with people who may have another idea about what that is? See another comment. I was able to pray with my mother-in-law and to commend her to her Lord and my wife, and to experience her release of her final breath, a very peaceful death, a good death. Thank you for sharing that. And so these experiences, for those who have been witness, both us as healthcare providers, but more so the family and the community around that person who's dying, those can stay with a person. And so trying to really honor and respect the needs of family. And then there's that complexity that creeps back in terms of what if there's different value bases, and I'm sure there's many stories that could arise from that in terms of what a person who's dying might want and what the family might want. And so there's just such layers of complexity, and going back to these contemplative practices is they can create the space to really hold that complexity and try and work with and navigate, and to do that with care and love, and I feel like I'm all of you who are doing this work already have a sense of this, and there are these practices can help us if we do them in the moments when it isn't all arriving and all this complexity is there in the room, but we can actually create that space by dedicating moments outside of those times to develop ourselves and our ability to stay with things. Okay, so I see we've got about 10 minutes left. I would like to, there's another practice I'd like to end with. So we won't do this practice, but I'll share another story. When I was working, I was in hospice, and a colleague heard me singing quietly under my breath and asked what I was doing. And that's one of my practices is to use sound to help me move and transform energy. And I guess in sharing that with them, it opened a door for them to share that they were having some trouble, and there was a lot going on for them. They hadn't been sleeping. They had a good friend who was quite ill in terms palliative, moving towards a palliative need for palliative support, and then doing this work in hospice. And I shared with them one of the things that I do when I go home after working a shift is to light a candle and to sit and to just think about, as they arrive, the people that I was working with, whether that be the person who had that really kind of seemed to me to appear to be in great deal of suffering, or the conversations that maybe didn't go so well, or I felt judgment, but I would light a candle and I would repeat some lines, and there's different lines that can be repeated. There's lots of different kind of mantras or turns of phrase. May you be safe from inner and outer harm. May you be well. May you be free from suffering. May you be at ease. May you be happy. May you be filled with loving kindness. And we could go on. What are some of those other phrases that might support, and again, that nurturing touch? You can also bring your hand to your heart, but I would sit with the candle and I would just imagine all the people that I had been caring for, and the family and my colleagues who I had worked with that day. And then I would end with myself. And in the traditional loving kindness meditation, you begin with yourself and then you move outward. And that's hard for some people, including me, because there's this real critical narrative. So for me, the opposite helps. So you can play with that and see what works. When I shared that with my colleague, she came back the next day and said, I tried your practice and I failed because I fell asleep. And I thought that was wonderful that she fell asleep, because she was having such a hard time getting to sleep. So also maybe letting go of the outcome of these practices. Carolyn, thank you. All shall be well, and all shall be well, and all manner of things shall be well. My favorite from Dame Julian of Norwich. I feel like we could end right there. Thank you for that. I also want to suggest, and as I did in the title of the book, Palliative Care Nursing is Mindfulness, Palliative Care Medicine is Mindfulness, Palliative Care Social Work is Mindfulness, that being with death and contemplating and caring for people in those big moments can be, because we're working to be present, we're working to stay with things, we're working to stay with people. It's a practice too, I think, a contemplative practice. And Sinclair did a paper, or did a research study where he looked at the personal and professional experiences of palliative care professionals. And it was called The Impact of Death and Dying on the Personal and Professional Lives of Palliative and Hospice Professionals. And what came through in the themes is that it's transformational, that this work supports living in the present, the wholeness, spiritual integration, moving from head to heart. So also just wanting to reflect that we're all doing it already. And then there's all these other practices that can help. So this last practice, I'd like to ask, we've drawn on the tree metaphor at the beginning, the sailing metaphor. You just saw the beach there, the sand on the feet, that image. And so to end and to think about holism in terms of our relationship also to the earth, to the land. Most palliative and hospice spaces have gardens, some real connection with nature. And so for this last minute, just offer you an opportunity to just sit either with your eyes closed or with a gentle gaze in stillness, and imagine your favorite nature space and just go there for a moment. And I'll end with a quote from a nurse. When nature is such that we're born, we live, we die. When you walk in the woods, the peace, the air feels different. When I breathe it in, it feels cleansing, it calms and grounds me. The feel of the air, more than anything else, it's intangible, but it's very real. Thank you so much for your engagement. I really look forward to being in a room with you and more conversation as time goes on. Thanks. And we have 5 minutes, so I'm here if there's any questions or we want to go any further. And you're welcome to email or, I invite ongoing conversation.
It looks like most of the stuff coming in right now is just thank yous to you, Lacey. So I can read some of these out now, but yeah, Beverly says, thank you, Lacey, for sharing your work and ideas. And someone else says, thank you so much. Very informative. I really appreciated it and learned a lot tonight. You did a great job.
Thank you. Thank you.
There's so many coming in that I'm sorry I might not be able to read them all out, but
That's okay. Thank you, everyone.
Yeah, lots of beautiful ones coming in. So I hope you have a chance to review those for sure. And I'm just gonna put in the post-session evaluation for tonight's session in the chat. And so if you want to receive your certificate of attendance, you can just fill that out. I'm going to email it out to everyone as well within the next week. So you can either fill it out tonight or you can fill it out next week when we send it out. And oh wow, so much more coming through the chat.
and I'm going to flip to the reference pages for those who want to know them on YouTube, and then for others, so you'll have them in the PowerPoint.
Yeah, someone says, thank you so much, Lacey. Very informative. I remember my first case. The son told me to look at his mom as dying, not a bad thing, but as a celebration. We should celebrate, or we celebrate birth, so we should celebrate death. Mm-hmm. That's very beautiful. And thank you so much to everyone for sharing their beautiful personal stories. There's just so many that were shared, so we feel very grateful